السلام عليكم جميعا وأهلا وسهلا فيكم مرة ثانية بعد طول غياب على محاضرات مبادرة أطباء العيون. اليوم نحن عنا محاضر مميز جدا، هو البروفيسور عمر مهرو. بروفيسور عمر هو طبعا هو متواضع جدا، فهو مسمي حاله دكتور، بس هو ما شاء الله عنه هو بروفيسور. هو استشاري طب وجراحة العيون مع FRC أوف من بريطانيا من لندن، ويعمل بمورفيلز آي هوسبيتال وبسنت توماسز بلندن. متخصص بأمراض الشبكية الوراثية، وعنده منصب أستاذ في علوم الأعصاب الشبكية باليونيفرسيتي كوليج لندن UCL. هو كمان أستاذ دائر في كينغز كوليج لندن. حصل على شهادته ودرجة الدكتوراه من كامبريدج، أكمل تدريبه في طب العيون بلندن. عنده أكثر من 200 منشور علمي بمجلات عالية التأثير مثل BNS, Nature Genetics, New England Journal و Ophthalmology. كمان أنه ألف 4 فصول في كتب علمية، وحصل على تمويل بحثي يتجاوز 2 مليون جنيه استرليني، ونال العديد من الجوائز العلمية. في عام 2019 حصل على جائزة النجم الصاعد للعام من ماكيولر سوسايتي، وعام 2020 حصل على جوائز التميز التعليمي والتواصل المجتمعي، وعام 2023 انتخب زميلا في كل من الرويال سوسايتي اوف بيولوجي والفيزيولوجيكال سوسايتي. كما انه عضو باللجنه العالميه للاعضاء في ارفو اللي هو المجمع البحثي بامريكا. عدة مرات تم عرض دعوته لإعطاء محاضرات عالمية، من بيناتها جائزة مايكل ساندرز بعام 2024. عام 2025 انتخب عضوا في مجلس إدارة ال ISCEV اللي هي International Society of Clinical Electrophysiology Physiology of Vision بصفته مديرا للمعايير. حاليا هو مسؤول التدريب الأكاديمي السريري في مركز الأبحاث الطبية الحيوية ال NIHR التابع لمورفيلز، ويشرف على الدورة السنوية لشبكية العيون المورفيلز ماكيولر كورس، ويشارك في رئاسة مناقشات أسبوعية لحالات الشبكية التي تعقد على الإنترنت بمشاركات دولية واسعة. ويرأس لجنة CBI اللي هي يعني لجنة إعطاء الشهادات العامة في المملكة المتحدة. Welcome, Dr. Omar. Thank you so much for joining us. And we really appreciate your time, and hoping that this will be a very useful talk for our colleagues in Syria.
Thank you very much. Can you hear me okay?
Yes, we can hear you very well.
Great. Okay, Assalamu alaikum, everyone. Bismillah. So it's an honor to have this invitation to speak. And I'll be talking about hereditary retinal conditions or inherited retinal disease. Usually I speak too fast, and this is going to be in English and not Arabic, and usually I have too many slides, so apologies if it goes very fast, but I'm happy to answer any questions and even be interrupted along the way. And also to be emailed afterwards. I can send my slides to anyone who wants them. And also, if you have any further questions, do get in touch. Other thing I'd like to plug is at Moorfields on Monday evenings, we have retinal case discussions on Zoom, Monday evening UK time, 5:30 to 7 p.m. That's open to anyone to join. So we have retinal specialists joining from all over the world, and you're very welcome to join and present cases if you like, or contribute to the discussion, or just sit and listen. So feel free to email and we can add you. So before starting, and I know you're in Syria and I'm talking about England and Wales, but just to make a point about what the top causes of blindness are in many countries, but I know most about obviously England and Wales. In working age adults, for many years, the biggest cause of blindness certification was diabetic retinopathy and then inherited retinal disease. But actually for the last now 15 years, this paper was published in 2014, but it was looking at data from 2010. The biggest cause of blindness in working age adults is genetic retinal disease or hereditary eye disease. Most of that is inherited retinal disease. So we often think of these as very rare conditions that we don't need to know anything about because hardly anyone's affected. Actually, when you put them together, it's the biggest cause of working age blindness in many countries. And in children as well, these are the biggest causes. And depending on how you group them, really inherited retinal disease is one of the biggest, if not the biggest cause of blindness in children as well. And this was just some work we did to look at since 2009-10 till just before COVID, what were the biggest cause of working age blindness registrations or sight impairment registrations. And it's hereditary eye disease is that blue line, whereas diabetic eye disease has been kind of going down, at least in England and Wales, over the decade, or not increasing, even though diabetes has increased. And it's partly because our treatment for diabetes has got better. Our treatment of diabetic eye disease with anti-VEGF agents, that's got better. In the UK, we have a very good screening system where everyone with diabetes has retinal photographs once a year, and any sign of trouble, they get referred to the hospital. So that's one thing that's helped keep blindness from diabetes down. But obviously, unfortunately for hereditary eye disease, most of them don't have a treatment. So this is what I want to cover in the next 45 minutes, hour or so, and let's see how far we get through it. We'll start with approach to patients. So when would we suspect a genetic retinal disease? And often trying to do things interactively isn't very easy on Zoom, but I don't know if anyone wants to say anything. What would make you think that my patient has a genetic retinal disease rather than some other cause like uveitic or age-related or something like that? Anyone want to? You can either unmute and just say random things, or you could.
إذا عم يدعيكم دكتور عمر إنه تقولوا إنه إذا حدا بيحب يكتب شيء، حدا بيحب يقول إمتى بتشكوا إنه مريضكم عنده مرض وراثي، عنده مرض الشبكية وراثي، شو هي الشغلات اللي بدكم عليها، أو شو هي البرزنتيشن تاع المريض، يعني وقت المريض يجي عندك شو بيخليك تفكر بالمرض الوراثي. فرجع نفتحوا المايك، إذا حدا حاب يحكي بيحكي عربي أنا بترجم له، بيحب يحكي هو اللي عم يشوفكم عم يقرا الكابشن تبعكم، فانتوا اذا حكيتوا عربي رح تقدروا. Someone is saying both eyes are affected in young age onsets.
Great. Yes, good. And I'm seeing things in the chat and also in the Q&A as well.
Family history, bilateral history.
Brilliant. Yeah.
This is what people say.
Excellent. Good. So you've covered most of it. Absolutely right. Something else in the chat. Family history. Yeah, family history. Exactly. So here we'll what we think about is bilateral symmetric is important because most genetic retinal diseases are bilateral and symmetric. So inflammatory diseases can be bilateral, but when it's completely symmetric, we think this looks genetic, but sometimes we get caught out. Drug toxicities can mimic genetic retinal disease. Some of the HIV drugs can give you a retinopathy that looks, many of my referrals, they're actually drug toxicities. They're not a genetic retinal disease. Hydroxychloroquine can look like a maculopathy. Pentosan can look like a pattern dystrophy. So there are some, so it's important for us to take a drug history in our patients. And as some people said, a young patient. So if you have something that looks like age-related macular degeneration, but the patient's 30, then obviously that's not AMD. And you might be looking at a genetic retinal condition. Family history, absolutely. Often, in fact, most of our patients, certainly in the UK, they don't have a family history. Most of the patients have autosomal recessive disease where they may be the only one affected in their family. And so it's not always there, but absolutely, if it's there, if there's a parent or a cousin affected with the same thing, then that would make you think this could be a genetic retinal disease. Yeah. And then the history. So someone mentioned history as well. So there are typical histories. And as ophthalmologists, as time goes on, we get less good at taking histories. We rely a lot on imaging and tests, and we don't really speak to the patient amazingly. But if you take a proper history, that can give you a clue as to what you're dealing with. So sometimes at an advanced stage, many retinal dystrophies can look similar, but the history is clear, is key. Often things get called retinitis pigmentosa. That's our commonest phenotype, and it's like a dustbin diagnosis of everything. But then you speak to the patient and they say, no, it was my central vision that went first when I was at school. And you think, well, that's not retinitis pigmentosa. That could be a cone dystrophy or a macular dystrophy, and the patient's got Stargardt's, and it's not Retinitis pigmentosa. With retinitis pigmentosa, it should be the night vision that goes first, then the peripheral vision, and then maybe the central vision later on in life. And sometimes patients aren't aware that they don't have good night vision. As you know, we live in a world with electric lighting, so we're rarely in a very a dark situation where there's little light and where someone would notice that their rods aren't working properly. So sometimes we have particular questions that we ask our patients. You have a patient with a widespread degeneration and they say, oh, it only started, I only noticed in the last few months or the last year. And you get worried. Is this some kind of autoimmune paraneoplastic retinopathy? How could all that degeneration happen in just a year or two? Then you ask the patient, okay, 5 years ago, 10 years ago, your vision was fine. Yes. But let's say you went to the cinema and you tried to find your seat in the dark. Did you need more help compared to someone else? Then it comes out, oh yeah, for the last 10 years that's been the case. Some people, oh, it's all my life I've needed help finding my seat in the cinema. I didn't think anything of it. One patient told me I followed the wrong woman in the cinema. I said, did you do it on purpose or because of your vision? He said, because of my vision. And another patient told me she used to sit on people in the cinema because she had no idea that the seat was taken. And obviously they'd get annoyed with her, but her vision wasn't good in those low light levels, or they have to wait until the end of the film and the lights are turned on again, and then they'll feel comfortable to move out of the cinema theater. Or someone will say when they go camping, they went camping maybe in childhood or early adulthood, and that's when they notice, because they're away from street lights, that for some reason I need a torch and no one else seems to need a torch. Why is that? And so that kind of history can be very helpful. Take a family history. So that's very important. And it was mentioned by some of you as a key. And what we always want is a family tree. So my fellows and residents in our clinic get annoyed because we insist on a family tree for all of our patients. They say no one else is affected. That means nothing, because the patient might be adopted, but maybe the patient's got no siblings, parents have got no siblings. You really
Sorry,
haven't got much to go on. Yeah.
I'm sorry. Are you using slides or not yet? Am I not seeing your screen then? Oh, sorry. I'm
You can see
confused.
it?
I'm sorry. Ignore me. I can see it now. Sorry.
Yeah, no
I was
worries.
looking at the
Yeah,
other one.
things
Sorry
are
about that.
coming up in this slide.
Sorry.
Yeah.
Sorry. Yes.
No worries. So absolutely important to take a family history and do a family tree if possible, because that will really then certain patterns of inheritance jump out at you when you see the family tree. When someone says, "Oh, the cousin's affected," well, what does cousin mean? If it's a male you're seeing and it's the mother's sister's son, it could be X-linked. If it's the mother's brother's son, it can't be X-linked. So we want to see a family tree for all of our patients. It's not enough to say, "Oh, no one else is affected," because you really want to know how many generations do you know about, and therefore that would give you a clue to the diagnosis. Sometimes we examine family members, so you're dealing with a male, a young male with vision loss, and you think this could be X-linked, I'm not sure, and you've got mum sitting there. So examine mum. We have this, quite easy to do an Optos autofluorescence, depending on what imaging modalities you have available. Sometimes you can do imaging undilated, and it shows a particular carrier sign telling you, oh, that's the diagnosis in the son, for example. So we do that a lot. Obviously, you've got to warn the relative. You might find something that they were unaware of. Consider syndromic associations. Again, as ophthalmologists, we're not always very good at taking a medical history, but some of these conditions go with kidney failure or something else. Sometimes we find the gene and we say, crumbs, that's actually also associated with kidney disease. Did anyone look at this patient's kidneys? Or they've been under the nephrologist for 20 years for renal failure. They didn't know what the cause was, and we're able to tell them, no, this is the cause, and maybe you'll treat them a different way. So sometimes, even though we can't treat our patients' eye disease, we can help our physician colleagues give them the right treatment. Imaging. So in our clinics, we get fundus imaging, multimodal imaging on all of our patients, OCT, autofluorescence, ultra wide field imaging. We still examine our patients with a lens because, you're an ophthalmologist and the patient thinks, I didn't see a doctor if they didn't look at my eye. But actually, the truth is we get a lot more from the imaging probably than we do from our clinical examination these days. Consider electrophysiology, so it's in red because I think it's very cool. It's not needed in every patient, but in some patients it can be really helpful to get the diagnosis. Not every patient needs it, and I often say, ironically, people get electrophysiology when they don't need it, and when they did need it, they don't get it. So if someone's got an advanced retinal degeneration, it's like knee-jerk, oh, let's get an ERG. Oh, the ERG is undetectable. We knew that already. That was a waste of time. But when there's, say, a maculopathy on the OCT, they say, well, I can see it. I don't need to get an ERG. Well, the ERG will tell you if they got a retina-wide cone dystrophy or just a macular dystrophy. So there it would have been helpful. Or if the imaging looks normal, but the patient's got a vision complaint, then electrophysiology can be critical. Genetic testing, again, it depends on what your availability is, but now we try to do genetic testing on most of our patients. We used to do single genes, now we do large gene panels, and actually in England now we do the whole genome for all of our patients, and we look at a few hundred. There's about 300 retinal dystrophy associated genes, and those are interrogated in those patients. Supportive measures we shouldn't underestimate. So it's always humbling and frustrating that as ophthalmologists, we're used to making our patients better with medical or surgical interventions. Unfortunately, most of our IRD patients, we can't do much to improve their vision at the moment, though there's lots of research going on, but we can still make a huge difference by getting the right diagnosis, counseling them, telling them what the risk is to future generations. Sometimes the patients say, well, doctor, I know you can't do anything about me, but what's the risk of having a child? And we can, by getting the right genetic diagnosis, tell them what the risk would be to future generations. LVA stands for low vision aid. That's the name of the clinics where our specialist optometrists give the patient magnifiers or try to improve their refraction to help their vision. ECLO, again, that's a UK abbreviation, but Eye Clinic Liaison Officer. Many of our eye clinics have these people attached who can signpost the patients to where they could get support. CVI is the Certificate of Vision Impairment. Again, that's a UK thing, where when you sign a patient as being sight impaired, that can help them access support. Family support, education support. Again, a child getting the right support early in life could make a huge difference to that child's trajectory through life. Maybe at school, the teacher just thinks, oh, this kid's not interested. They don't realize the kid actually can't see what's on the board. So then he loses interest and does something else. Whereas, if you identify a condition early, you get them support. Maybe they sit very close to the board. Maybe they have something else that will show them what the teacher's trying to show. And it can make a huge difference to their educational attainment. Treatable conditions or semi-treatable. Cystoid macular edema is a feature of many of these conditions, and sometimes it responds to carbonic anhydrase drops, not always, but sometimes. Cataract is common in IRD patients. That's something we can thankfully quite easily treat. Macular neovascularization, so CNVs, are common for some macular dystrophies, and in the era of anti-VEGF, that can make a huge difference as well. And then very rarely, like something like 0.5% of our patients or less have this Coates-like vasculopathy, not Coates disease, but something that looks a bit like that, where they have these exudative vascular lesions that develop, and some of them need laser early, otherwise it just quickly involves the whole retina. And then novel treatments or trials. I won't say much about that, but there are some gene therapy. There's only one approved treatment for one rare genetic disorder, inherited retinal disease, a rare one, and there are many others in trial phase. So knowing about that would be helpful, because many of our patients, we spend time talking to them about what's going on to kind of let them know that stuff is going on. And there may be something in the next 5 or 10 years, or what's being investigated at the moment, or there may be a trial that they're eligible for. Also, equally, this always sounds weird when I say this, but telling a patient that we know that there's no treatment at the moment is important as well, that there's no treatment that has any evidence for it, because patients increasingly are, searching the internet, and they'll come and they say, in such and such country, costing thousands of pounds, there's this treatment, will it work? Why wouldn't they? Parents would sell their house if there's going to be a treatment that's going to help their child see again. So sometimes our job is to say, look, we know what's out there, we know what there is evidence for, and this treatment that you've heard about, unfortunately, has no evidence for it. So we wouldn't advise you to, waste your money on that. And sometimes that can be reassuring to patients. At least they don't know, at least they know that they're not missing out on something that could be available somewhere. Because some of these people are very unscrupulous. They get the patients to sign a waiver that they're not going to sue them. Then they pay a lot of money for a treatment that doesn't work. And the patient can't do anything, or it makes things even worse. There were some stem cell clinics in the United States. There was a big New England Journal article about it, and they were blinding patients, and and it was going unregulated at that time. So we have to be careful. So the one approved treatment that that there is in the world is voretigene neparvovec. It's also called Luxturna, and that's for disease associated with a gene called RPE65. It's super rare, but it was a huge advance. We had 0 treatments. Now we have 1 treatment for one rare gene, but it's good because it means the field is moving. And for those few patients, not many, unfortunately, it's made a huge difference. And this was approved in the UK in 2019, and the first patients who were treated on our National Health Service were at Moorfields Eye Hospital in 2020. So that was a big step forward. Sadly, we haven't had another approved treatment yet that we has definitively worked and then got approved. There are other treatments. My colleague, Professor Michelle Nicolaides, led an intervention where AIPL1, which is even rarer, a disease, an even rarer cause of a very severe early onset retinal dystrophy, and they treated patients from other parts of the world as well as from the UK, and they did very well. You see the videos of the patients before and after, and it's amazing. But sadly, again, just one gene, super rare. Majority of our patients, we don't have anything. In terms of the future, when I talk to our patients about what the future might hold, people are trying to develop gene therapies for other conditions, for other genetic causes, where we can replace the faulty gene and restore function to remaining photoreceptors. Obviously, you have to have photoreceptors remaining for this to work. If all the cells have gone, then there's nothing to express the gene. People are also investigating stem cells, not worked yet, but hopefully will work in the future, where maybe we can replace the photoreceptors that have died with stem cells. Electronic implants into the retina, that field is, intermittently moving forward, where, okay, the photoreceptors have all died, but can we electrically stimulate the bipolar cells or the ganglion cells so that signals can be sent to the brain in response to light? And also optogenetics is another area of research where, even though the photoreceptors have died, can we turn, say, the ganglion cells or the bipolar cells into photoreceptors? Can we get them to express genes that make them sensitive to light so that they can then signal to the brain? So none of this is really working very well at the moment, but it looks promising. It's another reason why in our retinal dystrophy patients, we still want to preserve their optic nerve. In the old days, someone's got a pressure of 30, they've lost all their photoreceptors, they can't see much, and the eye's comfortable. Who's going to treat that? Actually, we treat those pressures now because we never know in the future that optic nerve might be needed if a treatment were to develop. And if they've lost it from glaucoma, then that won't be then helpful for them. So some resources that I think are helpful that I want to signpost you to. There's a review that one of my colleagues, Mihalis, largely wrote some years ago that summarizes, again, none of these things can be exhaustive, but the current situation and our current understanding of many inherited retinal diseases, rod-cone dystrophies, which is retinitis pigmentosa, Leber congenital amaurosis, that's an early onset severe retinal disease, severe early onset blinding condition, cone or cone rod dystrophies where the cones degenerate first, and macular dystrophies where the macula is affected. These are some web-based resources that I think are good. There's something called OMIM, Online Mendelian Inheritance in Man. And you can type in any gene. I try to get our fellows to take an interest in their patients because a gene has been found and the fellow's like, whatever, just a collection of numbers or letters. Just why don't you look it up and see what disease that patient that gene has been associated with? For retinal disease associated genes, then there's a very nice resource called RetNet, which is where inherited retinal disease associated genes have been collated. So that's a good resource. And then let's get my slides moving again. Yeah. Something called clinicaltrials.gov is a US based website where clinical trials that are occurring anywhere in the world and they've been registered on this site are listed. It doesn't mean it's a good trial. It just means it's registered on this site. And I often consult it because I want to know an update. Is anyone doing any research for this particular genetic cause so that I can inform my patients of what's going on? And another amazing resource that I can't, if you stop listening to me now, that's fine because you'll get more from this resource. It's called Stone Rounds, and there's a guy called Ed Stone, an eminent inherited retinal disease specialist, one of the world's greatest. He's based in Iowa, and he is behind this website as well, where that has many learning resources. So you can go to this website and it's all free and click Learn Inherited Retinal Disease and you'll see learning resources to learn about it. He also does live something called Stone Rounds, where he shows cases online and gets his fellows and even international fellows to present cases. And again, that's free to attend. Some of them are at Iowa time, US time, so it's like midnight in the UK and probably even early in the morning in Syria. But he does other sessions once a month that are more appropriate, say for European or Syrian time. So you can sign somewhere. It's anyway somewhere on this website you can sign up to the live Stone Round. So I would really recommend that. They've also developed a kind of questionnaire that they think every patient should be asked. And I think it's good to learn inherited retinal disease. What sort of questions should we be asking our patients? It's called the University of Iowa History Form. So you can access that from the website or from these slides. I developed something similar before I knew about this for Moorfields when we were adapting our electronic patient record, but we never, as many of the things, it never got incorporated. But there are certain questions we should try to ask every patient we see, and that's very helpful. So moving on to the next part of the talk is about family trees, and we're going to talk about our modes of inheritance. So the modes of inheritance that you all know, there are four main modes: autosomal dominant, which is, and then autosomal recessive, X-linked, or mitochondrial. And it's important to work out the inheritance because patients often want to know what the risk is, as well as helps us understand what the gene could be causing their disease, what the risk is to the next generation. So autosomal dominant disease, a child would have 50% risk of getting that variant and getting the condition. I put a little asterisk because autosomal dominant disease has something we call variable penetrance. For reasons that we don't fully understand, you can carry the mutation and still not get the disease. And it'd be great for us to know what is the modifier there, or what are the modifiers, because then we'd have an avenue for treatment. But it's basically 50-50, we say, or a bit less than 50% chance of getting the condition. So that's big. So it's obviously a big difference from something being autosomal recessive. Recessive is when there's a very little, they need to have a mutation, a genetic change on both alleles, the one from mum and the one from dad. And then to pass on the condition to their children, the child would have to inherit a change from the other parent as well. So the chance of a child being affected for an autosomal recessive condition, you've got an affected patient, what's the chance of my child being affected? We say less than 1%. We never say never. Anything is possible, but it's very unlikely, assuming an unrelated partner. So when there's consanguinity, someone partners up with someone they're related to, then the risk of a recessive condition is much higher. So that's an important public health message. As we know, many communities, consanguinity is quite common. And I feel sometimes that public health message isn't out there, that actually the risk of these conditions, especially if it's already in the family, goes up. Whereas with consanguinity, but the risk of being affected would go down if people marry out of the family. And sometimes there's a vicious cycle. People say, "Oh, that family is affected by this. No one marry into that family." Actually, that would kind of eradicate the condition if people married out, but they don't, because no one wants to, or they don't understand the genetics properly, and it keeps cycling generation after generation. So that's an important thing, I think, for us to know. X-linked inheritance, male-to-male transmission isn't possible. So a father can't transmit it to his son because the son has to have got the Y from the dad, not the X, otherwise it wouldn't be a boy, it'd be a girl. So that if we see male-to-male transmission, father to son, it means that it can't be X-linked. And mitochondrial inheritance is, as you may know, we get all our mitochondria from our mothers. So male to anyone transmission isn't possible for a mitochondrial disease. So we'll do a clinical case. Here's a 51-year-old, and she was referred by her optician, some difficulty with her night vision. The letter said that family members had retinitis pigmentosa. Patient might have a dormant form, whatever that means. Otherwise just had hypermetropia. And She was seen in clinic by our fellow, and I was really impressed with our fellow. She took a proper family tree. That's what we want to see from our patients. Most of the time, we don't see it in clinic, and we try to teach the fellows, look, draw one of these trees because it'll really help us get the diagnosis. So I've tidied it up. What do these symbols mean? Circles mean female, and square means male. If the circle or the square is filled in, it means they're affected by the condition. If it's open, the symbol, then it means they're unaffected, as far as we know. And the arrow means that's the patient in front of me. We call it the proband. And these are the different generations. So, these are the children of that couple, and these are the children here of that couple, and so on. And that diagonal line just means twins, but otherwise they're all kind of right angles. So if we look at this, we see our patient seems to be affected, and in multiple generations, there are people affected. So what do we think the inheritance is likely to be of this condition? Anyone want to guess? You can type it in the chat or say, or however you like. What do you think the inheritance is of those 4 types?
كله واضح عن دول الشجرة الوراثية. المربعات هي ميل، والدوائر يعني الرجال، والأنثى هي الدائرة. اللي عليه السهم هو المصاب مريضنا، واللي أسود يعني معبى المربع أو الدائرة هي المرضى بالعائلة اللي عندهم هالمرض هذا. فمين بيقدر يقول لنا شو نوع الوراثة اللي صارت عند هذا المريض؟ شو نوعها؟ هل هي سائدة، صفة سائدة، صفة متنحية؟ هل هي إكس لينك؟ هل هي ميتوكوندريال؟ شو رأيكم؟ تقدروا تفتحوا المايك إذا حدا حب يجاوب أو يكتب، حتى لو جربوا، حتى لو خطأ. Some people are saying autosomal dominant, recessive dominant. Sorry, changed his
Yes,
mind.
good,
Recessive.
excellent. And yeah, and well done. Khalil changed his mind, and absolutely right. Yeah. So some people, so we'd say unlikely recessive, autosomal recessive, because remember they need to have the mutation on both alleles. So what we're saying, and there's no consanguinity here, but even in consanguinity, this kind of like however many generations is unlikely, because what we're saying is this person had it, and then he just randomly, it happened that his wife, partner, was also carrying a rare mutation in this same gene so that they could have an affected child. And then not only that, she then met someone else who's carrying a rare mutation in the same gene to have 2 affected children. And then not only that, it happens again and again. That doesn't happen with autosomal recessive disease. It's like, unless it's super consanguinity or some tiny, village of a few families or something, it's like really unlikely that you'll ever see this many generations affected for recessive disease. So we'll say not autosomal recessive. And then we had autosomal dominant. Absolutely, this could totally be autosomal dominant disease, because there it's just one allele and it's coming through. So there's a 50-50 chance for each child. So totally, he could have passed on his good allele or his bad allele, and one child gets the bad allele, unfortunately, and therefore gets the condition, and that can happen again and happen again. So this could totally be autosomal dominant. But would I have made it that easy for you? No way. What else could it be? Could it be mitochondrial? Answer no, because if he's got the condition, this male, hopefully you can see my arrow, the male at the top, if he's got the condition, there's no way his mitochondria were inherited by any of his offspring, because they get their mitochondria from their mum. So it can't be mitochondrial. Male to anyone transmission is not possible. But what about X-linked? That was the other mode of inheritance we could consider. And the thing that would exclude X-linked is if we see black square to black square in the next generation. So father to son. And we don't see that, because that's father to daughter, then daughter to some daughters, then female. So there's a female transmitting to a male, but through a female who's apparently unaffected. So actually, we're not seeing anywhere where there's father to son, so X-linked is always possible. And you might think, well, X-linked should just affect males, but many conditions, some X-linked conditions, the carrier females can also be variably affected, but usually less severely than the males. So another good question to ask when you have a family with many people affected, were the girls and the boys, or the men and the women, similarly affected or not? If they say, oh, actually always the men were blind from early on, or went blind later in life, but the females never seem to be that bad, then that's a clue it could be X-linked. So that's exactly what happened with the fellow. I said, what do you think this is? She said, autosomal dominant. I said, could anything else be possible? Could be X-linked as well. So we should always consider that. And then when I looked at the phenotype, I thought, yes, we know what this is. This is, we get to, this, you can see there's pigment there. So someone might say retinitis pigmentosa, but usually that looks like what they call bone spicules. Looks kind of sharpish, and it's darker, it's blacker because it's intraretinal pigment migration, whereas this is grayer. And the Optos sometimes gives you funny colors, so you can't always tell. But the grayer thing means it's probably at the level of the RPE, and it looks a bit different. And then similarly the other eye, and then we do autofluorescence imaging, which is a bit more abnormal. We do the OCT. Even in the areas of abnormal autofluorescence, there's not outer retinal loss. So I recognize this as a carrier phenotype. We know it's the carrier phenotype for choroideremia. And that is X-linked. And it turned out in her family, the males were more severely affected. And in fact, because we've got such a big inherited eye disease service at Moorfields, we could look up whoever it was, the sister's son or grandson, and actually they had been diagnosed with choroideremia in our service. So that's important because we were able to get the correct diagnosis through a combination of the family tree and the phenotype. You could say, well, what's the point? You can't. Well, because it's X-linked, inheritance is very different. So we would advise people differently on what the risk is to having an affected child. And also there were some gene therapy trials. Unfortunately, they didn't work so far for choroideremia, but potentially, there was a potential treatment. Didn't work, but hopefully in future there'll be more trials that may work. And that's what choroideremia looks like in a male. Advanced, retinal atrophy. You're just seeing this kind of white sclera through it because you've lost pretty much the choroid and the retina. So there are other X-linked conditions where there's a carrier phenotype. Interestingly, X-linked retinoschisis, a female carrying a mutation in that gene, has no carrier phenotype. So the one thing whenever I ask this X-linked retinoschisis, because that's an excellent condition, it's called X-linked, that one has no carrier phenotype, but the other ones do have a carrier phenotype, and that can be helpful. You've got a boy in front of
Omar,
you.
do you mind
Yeah.
just explaining to us what phenotype means?
Oh, sorry. So phenotype means the clinical appearance. And here what I mean is what the retina looks like, what the fundus looks like on imaging. That let's say you have a male in front of you and they've got a retinal dystrophy and you've got the mum. Sometimes you see particular changes in the mum, even though the vision is fine. There are particular signs in the retina, and because she's carrying the mutation in the X, but she's got another X because women have females have two X chromosomes, and so she doesn't actually have usually doesn't have much in the way of vision symptoms, but may have signs in the retina, and that can help us work out what the diagnosis is in the child.
Thanks.
And so, for example, this is the carrier phenotype, the fundus appearance in ocular albinism carriers. So you may know there's ocular cutaneous albinism. That's when someone has very pale skin as well as no pigment in the eyes. That's autosomal recessive. But there's another condition called ocular albinism where the skin pigmentation is normal, but it's just the eye that lacks pigmentation, and you get the foveal hypoplasia and everything else that we associate with albinism. But it's just in the eyes, ocular albinism, and that's X-linked. So it only affects males, but the females, say the mum of your patient, may have this hyper and hypo autofluorescent streaks in the peripheral retina like that, and they have no visual symptoms, no vision problems, but they have that, and that will help you realize, oh, that's what the diagnosis is in the sun. So this is the ocular albinism carrier appearance. This is something we call a tapetal reflex, where the retina looks a bit shiny. Sometimes, not always, you see it more in the autofluorescence imaging, this radial streaks, and that's the carrier appearance in X-linked retinitis pigmentosa. So RPGR, which is the gene associated with much of X-linked retinitis pigmentosa, that's the subject of gene therapy trials. So again, helpful to identify that in males. It gives a severe retinal dystrophy. If you ever got more interested in X-linked retinopathies, then we published a big review a few years ago, 44 pages. I don't know if anyone ever read it, but summarizing everything like we thought might be important about X-linked retinopathies. And I came up with this algorithm. Again, no one will ever use it because it looks too complicated, and it's figure 26 of that review. That if you have a male with a non-syndromic retinopathy. Non-syndromic means no other organ systems affected, just their retina, not their hearing, nothing else. So it's non-syndromic disease. And there's an X-linked pedigree. You see the family tree and you see it's only males affected, connected through females. So this has got to be X-linked. Then you go through a few little stages and you can get it down to one gene or a couple of genes from the 300 genes that are associated with inherited retinal disease. So I find this helpful. So we've got an MCQ now. I was asked to provide 3 MCQs. Here's our first one. You've got a patient in front of you, a male, a man, and you've diagnosed X-linked retinitis pigmentosa. You've got, the genetic cause, and he's got a son. And he says, what's the chance of my son being affected, doctor? And you've got these 4 options. So I think hopefully you've got a way of saying what you think it is, and you can vote. And maybe give you
لو
like another.
سمحتوا كلكم حطوا الإجابات. السؤال هو مريض ذكر عنده retinitis pigmentosa X-linked وعنده ولد. هذا الولد الابن شو هي نسبة إصابته ب retinitis pigmentosa. So far we have people split between 50% or 0%.
Great. And someone's taken the
Mostly
average for
0%,
25% as well.
yeah.
Great. Okay, so maybe I'll leave it 2 more seconds and then we'll end
Yeah.
poll. I think I pressed that. Is that right? Okay,
Thank
great.
you.
And so I don't know if you can see the results, but certainly
Yeah.
some people, actually the majority, good, have said 0%, option D, and then nearly 30% have said 50%, and a couple of people have said 25%. And the majority were right here, so well done. The risk is 0%. Or we say very low. I mean, it could also be that the mum has a family history, but very unlikely. So as you know, a male has X and Y, and a female has an X and X. And the male has to get the Y from his dad because the mum can't give it a Y because she doesn't have a Y. So here, when a man has a son, he gives the son gets his Y, can't get his X. So it means that a male affected by an X-linked condition can't pass it on to his son. And so that's the good news. There's very little, unfortunately, good news in IRDs at the moment, but at least we can say the chance of maybe they have a son already or they don't have a son, and what's the chance? The chances are very little. If he has a daughter, there's 100% chance she'll be a carrier because she has to have got his X to be a female. But depending on the condition, let's say it was X-linked retinoschisis, they won't be affected at all. If it's something else, they may be mildly affected as an X-linked carrier. It can be hard to predict. But the next time a male will be affected is if then he has a grandson. If that daughter has a son, there's a 50-50 chance then for that son to be affected. So those who said 50% were right. If I was saying the man's daughter's son, but I wasn't saying that, I was saying the man's son, and therefore the answer is 0%. Great. So let's get the slides moving. Right, now we'll move on to imaging. What do we get routinely in our IRD clinics? We get OCT, fundus autofluorescence, and ultra-wide field imaging. Most IRD clinics get that. Not every one is a fan of autofluorescence, but we find it very helpful. So this is an OCT scan. Any comments on this OCT scan? Is this normal, abnormal? What's abnormal, if there is anything?
في شيء طبيعي السكان ما طبيعي حدا بيحب يعلق ممكن يكتب بالشات أو يكتب سؤال بالأجوبة الأسئلة ممكن يحكي إذا بيحب يرفع إيده ممكن نعطيه المايك. We have people saying straight away diagnosis, rod cone dystrophy. Khalil said ellipsoid disruption.
Excellent. And someone's got their hand up. Khalil, did you want to say something or you've put it in?
Ellipsoid disruption because I saw a patient 3 weeks ago with the same condition. I think that's the beginning of constant Rhodes dystrophy, in my opinion. I don't know.
Good. So very good. So you got the signs right. I think some more things coming. Let's see what they
Inverted
say.
saucer in
Okay, inverted saucer
Stargardt.
in start. Yeah. So start. We always say start with the signs and then try and work your way to the diagnosis. Just in case you didn't get it right, at least you get the points for the signs. So very good. Everyone got that. It's abnormal. Why would I show you a normal scan? And it's the ellipsoid zone that's gone away from the center. So actually, the center is the normal bit. And some people look at this and they say, what's that thing in the center? Because they see the rest of it looks like that. And our brains normally, that we assume most of it should be normal. And so the abnormal bit is the bit that doesn't look like the rest. And they think that's abnormal. But you all got it right. And you saw that the ellipsoid zone, which is this central line, is disrupted away from the center, but it's present in the center. In fact, a corneal consultant came to my clinic once and said, what's that? Pointing to the center in a scan they got on their patient. And I said, that's, that's the normal bit. That's why you're a corneal consultant. No, I didn't say that. I just thought it, right? Anyway, but well done. You all got it right. So there's ellipsoid zone disruption away from the center and so outer retinal loss, basically. And then we think about, well, what could that be? And someone said rod cone dystrophy, and that's a very good thought. This is a talk on inherited retinal disease, and you're seeing someone with preserved photoreceptors in the center, but they've gone away from the center, and we don't know how far out that goes, but if it went further out, then rod cone dystrophy is definitely possible. Any other possibility as well? Okay, first of all, I'm just going to show you a normal scan, in inverted commas, because my scan. Some people might not think I'm normal, but that's what the ellipsoid zone should look like, and it stops, either side of the center in this patient. Actually, this patient had not a rod cone dystrophy. They had something else. And it wasn't Stargardt. Someone said Stargardt. It was hydroxychloroquine retinopathy. So I put this here deliberately to remind everyone, always ask about the drug history. And obviously, the peripheral retina looked different from a rod cone dystrophy. But I have had many patients referred to me, and it turns out they've got a drug toxicity and not a genetic condition. And we get didanosine. So HIV patients aren't usually on didanosine now, but if they've had it for a long time, they probably were in the past. And many patients have been referred to me with a peripheral retinopathy. And I look at it, I say, that looks like didanosine. Then I ask them, do you have HIV? And it's because sometimes it's not mentioned in the letter, or the other doctor may not have known. Yeah. I think someone has their hand up. Yes, please.
Khalid wants to ask something?
Yes.
Does antidepressant cause any kind of toxicity to the retina, or it doesn't cause any kind of thing?
Yeah, normal antidepressants, obviously there are different types, but we don't know of any, and sometimes we'll find out later, but we don't know of any. There are some case reports with, I think, sertraline, but you never know. Some of these antidepressants are so common that the patient might have just had like a rare macular dystrophy or something, and I'm not really sure there's any definite causal link. Some of the anti-schizophrenic medications, though, can cause outer retinal loss. And so there are some that have been reliably associated, but not antidepressants as far as I know. Good. So now we'll move on to fundus autofluorescence. So that was OCT. And there are certain signs sometimes in some rare conditions on the OCT. We see a splitting of some of the layers, and it makes us think of certain conditions. But we'll move on to fundus autofluorescence. And that's when you shine in light of a particular wavelength, and the retina, usually the RPE, is emitting light of a longer wavelength. That's what fluorescence is. But because here we're not injecting fluorescein or any dye, it's just happening without you injecting anything. We call it autofluorescence. Though really it's just fluorescence, but we call it autofluorescence because we're not using a dye. So this is a teaching slide I give for autofluorescence. Just as when we learned to interpret fluorescein angiograms, we learned what makes something hyperfluorescent, what makes something hypofluorescent. You can do the same for autofluorescence, but the causes are different. So you could have increased fluorophore, some more stuff there that's fluorescing, or if you see hyperautofluorescence, it could be that you've just lost the photoreceptors that are overlying that area, so more light goes to the RPE, and therefore you get a brighter signal back. So window defect here doesn't mean RPE loss, which is what it means in a fluorescein angiogram. I mean here photoreceptor loss. You lose the photoreceptors, more light goes to the RPE shines brighter, and therefore you see a hyperautofluorescent bit. Or you get lower autofluorescence, either because you've lost RPE, or because there's some gunk in the way, you get masking. So I've just highlighted here the things that are relevant to inherited retinal dystrophies that can show up on autofluorescence. And also this group of genes here, which again, you might think, what are those genes? Are important because they affect the visual cycle, the recycling of retinoid in the retina. And if those are defective from the get-go, from birth, then often the fundus has very low autofluorescence, even before you get much degeneration. So that's a clue. And why is that important? It's important because the one gene you never want to miss is RPE65, because the one gene where there's actually could be a treatment for your patient, one rare cause. But one of the signs of that is that the autofluorescence, even before there's much degeneration, autofluorescence is really low. We call it the photographer apology sign. So our photographers at Moorfields are excellent. And when they come to us and say, I don't know why, I just couldn't get a good image. There's like no autofluorescence there. Could be RP65. You never know. And if it is, then there may be a treatment for this patient. This is the classic autofluorescence appearance in Stargardt disease. Sometimes you see yellow flecks when you look, but when you see autofluorescence, they show up a lot more. That's associated with this gene ABCA4. Different phenotypes, but they're all associated with variants in this gene. Sometimes you lose the whole of the center, but you see still these autofluorescent flecks, different phenotypes. Sometimes it can be widespread depending on the genetic variants. Even when it's widespread, you often get peripapillary sparing. Sometimes it's so bad you even lose that. In RP, retinitis pigmentosa, which can be caused by many different genes, you often get this hyper-autofluorescent ring that we call the Robson ring after Tony Robson, now head of electrophysiology at Moorfields, who first described this ring. And it's the border between normal retina on the inside and abnormal retina on the outside. So when we see these Robson rings on autofluorescence, that's a sign the patient could have RP, even when you don't see much pigment in the retina on clinical examination. For some reason, we still don't understand why some types of RP, even the same type of RP in different patients, you get less bone spicule pigments. But when you see this hyperautofluorescent ring, it's a clue that it could be RP. For some macular dystrophies or cone dystrophies, it's the other way around. You get a ring, but it's abnormal inside and normal outside. I call that the Nosbor ring because that's Robson backwards, but I don't know if he appreciates that or not. But anyway, so sometimes you get a kind of other way round ring. And then this is actually, that was someone with dominant RP. This was the father who had much more advanced RP, and you lose that hyperautofluorescent ring. And that's just showing it in another patient. And you can see it's the border between normal and abnormal retina, which you can see on OCT. So just at this border here, that's where you get this hyperautofluorescence. And he showed it before OCT. He used pattern ERGs to show that's what it was. And then obviously OCT was invented later. But we have new descriptions. For example, here are some patients with what I was mentioning where they have abnormality in the center, but it's the center that's degenerated and the periphery is kind of relatively normal. So that could be a macular or cone dystrophy, some of them. But these are some patients where it's a bit weird because not only have they got that central degeneration, they've got another bit of nasal retina far away from that central bit that's also degenerated, that's also symmetrical in both eyes. And I started seeing this now and again, and I realized this almost only do I see it associated with one gene, and that's a gene called CRX. And hardly ever do you see this kind of pattern associated with other genes. And still, most CRX patients don't show this, but about 10% maybe do. And when you see it, you think CRX, and it helps us get the genetic diagnosis in those patients. So we're kind of discovering new patterns all the time, and we published that last year. So a few words about electrophysiology. I'd love to talk for hours about electrophysiology. You wouldn't love me to talk for hours about it, but I think it's important for many of these conditions, but I'm not because we haven't got much time. But just to say in some of these conditions, and again, I can send these slides to anyone who wants them, I think it's helpful. When you've got clear retinitis pigmentosa, I think it's less helpful. You know you're going to see a rod cone dystrophy on ERG. We call it rod cone because the rod's affected more than the cones. If it was the other way around, cones affected more, we call it cone rod. You know what you're going to see, but in other conditions where you just have an abnormal OCT, you don't know about the rest of the retina, or there's normal imaging, and you're not sure what's going on, then ERGs can be helpful. And there are some, these are normal ERGs on the left, and then we have different types of inherited retinal disease condition, not all of them here. Rod cone dystrophies, RP, many genes. But there are some other patterns that really narrow it down just to a few genes. So achromatopsia is when the cones don't work from the start and you get the ERGs and there's no light adapted response, they're undetectable, but the dark adapted responses are normal. That's achromatopsia, and it's a stationary condition, and it narrows it down to a few genes. There's some other things called congenital stationary night blindness, complete and incomplete. They give you what we call an electronegative ERG, the way the ERG just goes down but doesn't come back up to baseline, the DA10, the bright flash delivered in the dark, and they give you different shaped light-adapted ERGs. I have another talk where I tell everyone that they should have learnt this shape at nursery, because if you recognize that shape down there, you know your patient's either got complete CSNB or they got MAR, melanoma associated retinopathy, and you've got to look for a melanoma. So that shape is quite characteristic. Anyway, that's too much for this talk. So if you want to know about where I think electrophysiology is heading in the future, then I published a review a few years ago about the potential of the potentials, a little pun there, about where electrophysiology might go in the future. Also, the electronegative ERG, I think, is a useful sign because that can narrow down the genetic differential diagnosis considerably. And we published a review on that a few years ago, so have a look at that. Another multiple choice question, right? So which of the following conditions is not associated with an electronegative ERG? The DA10 means the bright flash, 10 candela flash delivered in the dark. And 3 of these conditions will give you an electronegative ERG. That could be helpful in telling you the diagnosis, but 1 of them won't. Any thoughts?
تفضلوا جاوبوا. كان سؤال مهم في شكل معين مثل ما شرح الدكتور عمر، هو الالكترونيجاتيف اي ار جي. اي من هي الامراض ما بيعطي الكترونيجاتيف، يعني البقايا كلهم بيعطوا الكترونيجاتيف. So far people are leaning towards achromatopsia.
Good. Excellent. So we'll let it run for a few more seconds, and then I'll press end poll. Well done. So the majority got the right answer again. Remember, I've asked which is not associated. That's again the trick in sometimes multiple choice questions. So the first 3 do give you an electronegative ERG. Complete and incomplete congenital stationary night blindness, they always give you an electronegative dark adapted bright flash response, and X-linked retinoschisis often does, but achromatopsia doesn't. Achromatopsia gives you absent cone system responses, but normal dark adapted responses. So if we go back to, let's get these slides moving again. That's achromatopsia, where the light adapted response is undetectable, but the dark adapted response is normal, whereas congenital stationary night blindness, CSNB, gives you an electronegative DA10 response, and X-linked retinoschisis, which I haven't put here, usually it's electronegative, though not always. Good, great. And that's helpful because some of these are stationary, some of these aren't, and then also something that can look like achromatopsia, but it's actually CABP4, the electronegative ERG tells you it's different. And sometimes they also get misdiagnosed as LCA. So in those conditions, I find ERGs helpful. Right, so I'll try and go a bit more quickly because got a little bit more to get through. Genetic testing. Why get a genetic diagnosis? That's a very good question. And absolutely, depending on your local resource availability, what do you prioritize? Maybe we prioritize conditions we can treat. So someone's got, proliferative diabetic retinopathy, you laser them. There are things that we can do for patients. And so people often will ask me, they maybe put it more politely, but basically, why are you spending so much effort trying to get the genetic diagnosis in these patients when actually there's no treatment for most of them? Well, one of them there is, so you wouldn't want to miss that. But these are the reasons that are often given. 1, you have a better understanding of the disease. If we get the gene, sometimes we know how different genes pan out, and so we can give some prognostic information. Patients often want to know what's the risk to my children, as we've said before, and when we find the correct gene, then we're more likely to be able to tell them what the risk is. And there are some gene-directed therapies, only one approved one, but there's some others in trial phase where you need to know what the gene is for them to be eligible. Because, for example, for Luxturna, it's an operation where the retina, the seeing bit of retina, is being detached. That's got loads of complications. It might blind the patient. So you want to be damn sure that this is the cause of your patient's condition before you enroll them for, say, Luxturna treatment. So that would be very important. Understanding the systemic implications is also important because some genes, some changes in certain genes don't just affect the eye, they affect the kidneys or something else. So we might not be able to help our patient's eye disease, but we could get their kidneys screened or something else and help our physician colleagues give them more appropriate treatment for whatever else they have going on. Also, there's a couple of other things that people often don't consider, but I think are important. The other thing is excluding a non-genetic etiology. Because if you find a genetic cause, okay, there's no treatment, but whatever else they thought it was, it probably isn't that. So there are these patients who bounce between uveitis and genetics. Oh, I think it's inflammatory. No, I think it's genetic. I don't know. And some of them are on immunosuppression, right? Because if someone's got a progressive inflammatory condition, you want to really do your best to stop it progressing. And so it's happened quite a few times actually now where we've been able to stop patients' immunosuppression because it was futile, and immunosuppression has risks. So somehow we realized, got referred to me, and I thought, well, actually, I think this is genetic, not uveitic. We get a positive genetic diagnosis. There's no doubt that there's a genetic cause. Unfortunately, there's no treatment, but maybe all this stuff you're on, we can stop and help you systemically because you don't need to be on steroids or second-line immunosuppressants because it's not necessarily going to help. Or we found a genetic thing that we know is stationary, that's even better, and we know it's not going to get worse. Or sometimes explaining part of the phenotype, the patient's clinical appearance, because sometimes we think the patient should only have one thing. Occasionally they have more than one thing. They've got some progressive thing. They've got weird ERGs that freaks everyone out. We found, oh no, the genetic cause of the weird ERGs is a stationary thing. Forget about that. And then you can deal with something else, is not related to the ERGs, and you see what might be happening there. This is just a rare example, but I feel it drives the point home. This is a patient I was shown the images. So I do a Friday afternoon clinic. Zayn will remember many years ago, we had a great time working together at St. Thomas's, and that Friday afternoon medical retina clinic I now do as a joint clinic with Moin Mohammed. So we have that clinic, and sometimes the casualty guy, the guy from the emergency department, will walk over and show us a scan, and so then it's shown to my colleague, then shown to me what's going on here. And so can anyone tell me what's weird about this OCT?
هذا بيحب
Any
يعلق
thoughts?
الاو سي تي شو الشغلات المو طبيعيه بالسكان، حتى لو وصف ما ضروري التشخيص، اكيد هو وصف الحاله. تقدروا تكتبوا او تقدروا ترفعوا ايدكم وتجاوبوا لو حبيتوا.
So someone said hypoplasia. Actually, they didn't have. I probably confused. Yeah, maybe if that's through the center, you're right. They've got very mild foveal hypoplasia, slight persistent inner retinal layers, or maybe it wasn't quite the center. But good thought. But that's not what I wanted people to notice.
Hyperreflectivity in outer.
Yeah, excellent.
Somebody said outer retinal layer. Somebody said outer nerve layer.
Absolutely right. And then. Yeah, absolutely. Excellent. So the outer nuclear layer looks abnormal because of these hyperreflective foci, and they're at the level of the external limiting membrane. Even more important because there's something else that can look like this, which is CRB1, but the outer retinal hyperreflective foci go down to the ellipsoid zone and give you a defect there as well. So that's not here. So someone very correctly said it's the level of the external limiting membrane. And that with no atrophy or anything else going on, I had only seen in something very rare this particular appearance, and I'd only seen it a couple of times, but I was able to say this is, it made me ask about the patient's heart because I'd only seen it in something called Danon disease, which is associated with a gene called LAMP2, LAMP2, and it gives you a hypertrophic cardiomyopathy. And it can give you changes in the retina. And so I said, because I knew nothing about the patient, right? This is how it is nowadays. We see the image before we know anything about the patient. So I said, how's his heart? And they said, well, actually, he's under the cardiologist, but an optician had seen something abnormal in the retina. He had some pigment in peripheral retina as well. And that's why they sent him to us to have a look. I said, oh, right. So they probably know he's under the cardiologist. They probably know the diagnosis. He's a 16-year-old boy admitted with heart failure. But I'm just going to, write a letter to them to say the retinal findings very specific for Danon disease. I just want you to know that in case you don't already have the diagnosis. So it's always important to communicate. Then I thought after clinic, I should go up to the ward, right? So after my clinic finishes 6 or 7 o'clock, I wander over. Cardiology ward is 7th floor. Luckily, there's a lift. I could do 7 floors, but I had an observer with me. So we went in the lift anyway. I went to the patient. My letter is just folded up next to the glass of water. Nurse said, "I'll show it to the doctors on Monday." This is Friday night. I said, no, we need to, I don't know, maybe they know the diagnosis, but I want to just talk to them to be sure. So I talked to the cardiologist. I also emailed them. I got an email back Friday night, like, thanks, but no thanks. We think he's got a cardiac vasculitis. Saturday, another email back saying, we've now re-reviewed all his cardiac imaging and we think you're absolutely right. This is Danon disease. There's only 3 centers in the UK. He got referred to one of them. They did rapid genetic testing to make sure it was LAMP2, just to be sure that I was right. And he got a heart-lung transplant. This was a few years ago, and now he's doing fantastically. And even a year ago, when I saw him in clinic with his mum, she said, "Oh, you saved his life." And I wanted to say, can you say it louder? Because these guys think I do nothing with my genetic retinal dystrophies and they're saving the world with their blepharitis or whatever, CSR or something. But, occasionally, obviously I didn't say that, but occasionally we can do some good by recognizing a rare disease that will help. Can't do anything about his retina, and actually his vision, thankfully, is quite good. But it could tell us, and it's unusual for a male to have a mild retinopathy, and it turned out he was a mosaic in the end. He had some X's that were okay and some that had this mutation, but it allows us to really help him systemically or help our physician colleagues get the right diagnosis. So that, So now to talk about genetic testing, usually that doesn't happen, obviously, but it can. We used to do single genes. Now we do large gene panels, and actually in England we do the whole genome. So there are 3 billion bases, but then they only look at the 288, nearly 300 inherited retinal dystrophy associated genes. And we now we have a whole it's not just the ophthalmologist, obviously the geneticists involved, molecular biologists. We have a whole team that discusses the results and to try and work out whether the genetic changes we're finding are the cause in our patient. This is the whole genome printed out at the Wellcome Trust. I took a photo a while ago, and you can take out your favorite chromosome, have a good read. Luckily, we've got computers now that can do this. We had something called the 100,000 Genomes Project in the UK that made the UK a world leader at that time in genomic medicine, and a few thousand of these were inherited retinal disease patients. And we made a lot of discoveries that have helped us get the right diagnosis in our patients through this project. So I annoy my fellows because we want to know the genetic variant. They've guessed the gene, and it's like, I'm still not satisfied. Guessing the gene is like, high school level. I want you to tell me what the variant should be, or does that go with this phenotype? So it's like we have to go back to medical school and remember how a gene's structured. They have these coding regions called exons, and 3 bases, you might remember from medical school, code for each amino acid. So how am I going to illustrate this? I thought, can I think of a sentence that has only 3-letter words? The fat red cat met the hen and did not eat the rat. So it took me a while to think of that. So imagine one base gets changed, one letter gets substituted for another letter. That thing is wrong, but the rest of the protein might be fine. We call that a substitution, a missense change, and depending on how important that amino acid was, it might have a mild effect. Imagine if you have a different change where a base got deleted, what happens? The thing is reading 3 at a time. It doesn't know there's one missing, so everything moves. Now the whole thing is nonsense, and none of those words make sense apart from her at the end. So that is, we call that a shift in the reading frame, and usually those things are worse. So we're now getting to grips with different mutations, different genetic changes give you different phenotypes. So we want to know, because if we get the wrong association, it happens often. Dominant disease, usually it's a gain of function problem. It's not a frame shifting mutation. And again, and even at these international meetings, and I become unpopular because I say, no, you're wrong. That's not the cause. That it wouldn't associate with this phenotype. But it's important because we get the wrong diagnosis in our patients otherwise. Unless, of course, you had a deletion of how many? How many could you delete and you wouldn't shift the reading frame? Who's good at maths? Anyone want to say? How many if you deleted? Any thoughts? Maybe it's too easy for you. So if you deleted 3, right? then you wouldn't shift the reading frame. So imagine if you deleted 3 bases, then yeah, that amino acid is missing. So that could be bad or might not be bad, depends how important it is, but the rest of the protein might be okay. We call that an in-frame deletion, you see, because it just reads along and everything else is okay. And often that's less bad. Sometimes it is bad, sometimes it isn't, but we're getting to grips with different mutations do different things. Another thing we're seeing is that non-coding regions, there's this whole section of the genome we used to call junk DNA. It doesn't do anything. Actually, it's important for other reasons. And if you have mutations in those regions, you could still get a disease. So I always say it's dangerous to call anything junk. I tell my wife that all the time when she throws out all my stuff and says it's junk. And then 5 years later, we said that thing was really important, right? It was holding up the house and we didn't realize it. Anyway, in these regions that we thought were junk, you can get changes that still cause disease. Right, final MCQ question for this talk. Which of the following would be an in-frame deletion?
مثل ما شرح الدكتور شيء اسمه الام فريم ديليشن، يعني 3 بروتينات راحوا.
Good. So Zain, you already gave the answer because you said
Answer,
thalatha,
sorry.
which means 3.
Sorry.
Well, just because in Arabic I wouldn't tell, but yes. Good. So lots of people are saying 1, 4, or 9.
It's actually very
Good.
close. Nearly.
Good. So
Yeah,
we'll
people
end the
leaning
poll in
more
a
on
couple
9
of
days.
seconds. Excellent. So the majority have got it right again. Deletion of 9 bases would be in frame because it's a multiple of 3, whereas 1 base wouldn't, 4 wouldn't, but so it's got to be 3 or a multiple of 3. So Zain didn't give you the full answer, which is
Sorry.
good. A multiple of 3 would also give you an in-frame deletion. So if we go back to our this thing, so if you deleted 3 or 6 or 9, you'd still be in frame and the rest of the protein would be all right. But if you delete 1 or 4 or 2, then it's out of frame. It's like 1 would give you that same thing. So good. Okay, so now this is a little algorithm. I just want to show what things used to be like and what things are like now. So it used to be you took a history, examine, maybe do some imaging. You think, it could be this gene. You sequence a single gene, you get the answer. Or you don't get the answer, you have to think again, sequence another gene, you might get the answer. Now, in many places, maybe not everywhere, but in many places, you take history, examine, you think what the genes might be, but you sequence a few hundred genes, or maybe the whole genome. So you don't even need to think what was the likely associated gene. You just do everything, right? That was the thought. Actually, it's not the case, but that was the thought. You just get the answer, right? This smells genetic. I don't need to think. Just throw the whole genome at it, do the big genetic panel. I get the answer, job done. Of course, it turns out that doesn't work. Often you get lots of answers because many people, you, me, everyone, we have rare variants in different genes that maybe hardly anyone else in the world has, but it's not doing anything. It's just, that's me, that's you. And they could even be in IRD genes and they're not doing anything. So we get lots of answers, and these things are called variants of uncertain significance, and we don't know if it's causing the disease in our patient or not. So it turned out we had to know beforehand what were the likely associated genes, because then we'll know which of those variants is relevant. So often when I do my letters, I say, I think this patient has a genetic disease and it could be this gene or a few genes or whatever. I always say it could be or other genes are possible. I don't want to say it definitely is because then it's what they call notes law. Then the next patient says, oh, it's definitely this because someone had said that previously. But I try to say what the possible genes are. Why? Because when I get many months later the genetic test result and I've forgotten the patient, but I see a variant of uncertain significance and it's in one of the few genes that I'd already said I thought it was going to be, then I'll take that seriously. So rather than, people retrofit to fit the data, they try and force something into something it isn't. But if I already said that gene and then they found a variant in that gene, then that's pretty strong evidence that could be the cause. Or we get a negative result, and then again, we can't look at the whole genome again with a fine-toothed comb, but we say, well, what gene was likely? Let's just look at that gene again and again and again in more detail and see what might they have missed, and then we might find the answer. And of course, then we'll have AI and that will do it for us. Probably not, but anyway, until that time, we still need to be thinking about what the likely gene could be in our patients. So just a couple of things before we finish. The top 20 genes, we did this study at Moorfields Eye Hospital. We have one of the largest genotyped IRD cohorts in the world, and it's allowed us to get an idea of the burden associated with different genes. And so we published this a few years ago. Now we have over 4,000 families with a genetic diagnosis, and we could plot, what are the commonest genes. And in most parts of the world, the common genes are similar, not always. And the most common gene that we encounter by far is ABCA4. More than 20% of our genetically characterized patients have mutations at ABCA4, which gives Stargardt disease. And then we have all these other genes. I'll skip over this, but I can send this down. These are our top 20 genes. And it's given us an idea of when we see retinitis pigmentosa, many genes are possible. But if we think it's autosomal recessive, then our likeliest genes are USH2A, EYS, then a whole load of other ones, including ones involved in phototransduction. If it's dominant, we see many generations affected. We're sure it's dominant because there's father to son transmission. Then these are our big three genes, but there are some others as well, quite a few others. X-linked RP, the most important gene, most common gene is RPGR. And that's important to know because it has a region that's very repetitive that always gets missed on whole genome sequencing. They never sequence it properly. They can't. It has to be sequenced specifically. So again, if you think it's RPGR, you might need to do a different test, which is important. For macular dystrophies, commonest ABCA4, and then these are some of the others, and some are dominant, some are recessive. That's important in terms of counseling the patient. And then more recently, we had this excellent fellow called Serene Lin, who's now a consultant in Manchester. She looked at our cohort again and looked not just at gene level, but at variant level and what are the commonest variants. And we published them as well, because that's also of interest. Other developments, we keep discovering new genetic causes, new genotype phenotype correlations. We have these big natural history studies. And also we correct many previous mistakes. So here are some examples of papers published 10 or 20 years ago on the left. 10 or 20 years ago, we didn't know anything. We probably just found out the Earth wasn't flat. But now, recently, we now realize actually that paper was wrong because we didn't have the knowledge available then that we have now. People would find a change in their patient and then they sequence 100 healthy people, say, oh, this must be the mutation. Now we've got these big databases. We can look up our gene variants that we find and see how rare really is it. So these are the correction papers for those ones, just some examples. And at the moment, I'm smug because I'm on the right-hand side, but just give it a few years and some other guy will be correcting my mistakes. That's fine. That's how science progresses. But just in the last month, we publish a few papers every month with some new discovery in inherited retinal disease. So I'm trying to show you that this is the most happening bit of ophthalmology. Sadly, the treatments aren't coming yet. That is frustrating, but let's hope that there's lots of research going on. But we are understanding more and more. And this is just, this month, and these are largely collaborative efforts. As you can see, loads of authors on many of these things, rare diseases. We try to pool our resources. So now, just to end, I've got a few case examples that have some twists. I'll never show you something straightforward, but I find the twists often interesting and there are more learning messages. So this is a 42-year-old Eastern European male who was referred to my clinic. Actually, over 10 years prior, he'd lost vision in one eye subacutely, and then he lost vision in the other eye. So what do you think the diagnosis might be? Any thoughts?
هذا
You
اللي
can
يحب
write
يحكي
it or
يقول شو
unmute.
رأيه. شو برأيكم؟ عمره وقت كان عمره 31، النظر بالعين اليسار اختفى خلال أيام أو أسابيع، وبعدين اليمين بعد 3 أسابيع.
Good. So I see.
LHON, Sarah.
Yeah, excellent. Good. And then, and some other things as well. So
Howardson,
LHO1, absolutely. Obviously, it could be other things as well, and we need more information. But that's the classic history. Usually, it's a male. One eye goes, then the other eye goes. It's a mitochondrial disease. And he was diagnosed with LHON. Obviously, he was worked up properly for other causes of an optic neuropathy. He had neuroimaging, everything else excluded. This was likely to be LHON. He had a bit of progressive loss since, which can happen, counting fingers when he saw me. He was tested for the 3 common mitochondrial mutations, for LHON and he was negative. That can still happen, but made it a little bit more unusual. Then he was recruited to the 100,000 Genomes Project. He had whole genome sequencing, and they found two changes in this gene called EYS. And if you're listening carefully, you would remember that I said EYS is a gene that gives you autosomal recessive retinitis pigmentosa. You'd have missed it because I speak very fast. But anyway, EYS isn't associated with optic neuropathy. It's associated with retinitis pigmentosa. That's why he got referred to my clinic, right? So, these silly neuro-ophthalmologists, they don't know what they're doing. And the guy had RP and they're calling it LHON. What's going on? So then we look at him in the clinic and actually he's not got RP. His retina looks pristine, Optos images. Discs were a bit pale on Optos. It can be hard to judge the color, but ultra-wide field autofluorescence, not a hint of degeneration, no Robson ring. This isn't retinitis pigmentosa. His OCT, outer retina, is pristine. What's abnormal about this OCT? What do you think? Anyone? Or is it
شو
normal?
برأيكم الأو سي تي طبيعي ولا لا؟ I might say actually it looks normal to me, but I don't know if the NFL is gone on the right and the left eye.
Great. Excellent. So it looks so because we're retinal specialists, we obsess with the outer retina, and that looks pristine, but we forget about the inner retina, and you're absolutely right. The RNFL is gone. So it's so cleanly gone that you don't even notice, which is I always try to teach people to count the layers. So this is the outer nuclear layer, if you can see my arrow. Then there's the outer plexiform, then the inner nuclear layer, then inner plexiform. Then there should be a ganglion cell layer, and there should be a nerve fiber layer. And you can't see that in either eye. Another way is if you look at, I mean, this is quite a wide image, but let's say you had a typical 6mm macular scan and you don't look at the infrared image, can you tell which eye it is? Normally you can tell which eye because you see the nerve fiber layer on one side. If you can't tell which eye, either they've done a vertical scan to confuse you or there's a nerve fiber layer loss. So the patient's got an optic neuropathy. And unfortunately, I've seen optic neuropathies missed by retinal specialists because we just look at the outer retina and people forget to look at the inner retina and forget the optic, the nerve fiber layer is cleanly gone and the ganglion cell layer in this patient. So those neuro-ophthalmologists were absolutely right. This was an optic neuropathy. Phenotypically, this is LHON, and so it does it is consistent with that. So what do we do then? He had these variants in EYS. So this shows that actually, because that's never been associated with an optic neuropathy, they're probably not relevant in him. One is what we call a stop mutation, that the mutation turned into a stop codon. That probably will abolish protein function. But the other change, maybe that's just a rare variant that doesn't cause problems, or maybe it's on the same allele, and therefore he doesn't have a problem on the other allele. These are possibilities. Whatever we know is his disease is probably not associated with EYS. This is irrelevant to his disease. So what do we do? So then I phoned a friend, right? I have got friends, contrary to what people might think. And this is Dr. Naringa Jakuti, who's a specialist in, she's a neuro-ophthalmologist, but a specialist in inherited optic neuropathies. I said, I took consent from the patient, can you look at this patient's data and find an optic neuropathy gene? She was able to identify him by those EYS variants, because they're very rare. And she found that actually he had homozygous variants, meaning on both alleles, in this gene called DNA JC30. And that turns out is the commonest autosomal gene that gives you an LHON phenotype. And it was just around that time that this thing had just been published, that DNA JC30 mutations in this gene can mimic LHON, but it's autosomal recessive. It's not mitochondrial, but it affects mitochondrial function. So it gives you males more than females, and one eye, then the other eye. So exactly like LHON, that's why they call it a phenocopy. Copy is the phenotype, but a different genetic cause. So we were able to find his variants and get the right genetic diagnosis in him. And this is just an example of increasingly this is happening. It used to be, I see the patient, I think, let's get a genetic test, let's get the results, let's interpret them. Now the patient comes to me with their test. They've had it done elsewhere. And then I've got to work out, is that test result really relevant to your disease or not? And still the phenotype, meaning the clinical appearance and the symptoms and signs, guides whether those genetic findings are true or not. The advantage of having done a big test before is we didn't even need to take another blood sample. We could just look at his data again and to look for optic neuropathy genes. And it's always good to have friends who can help you find the answer. So there's a very collaborative approach. Right, 2 more cases I'll do quickly. This is an 11-year-old boy. Vision, as you can see, is a bit subnormal, and that was his fundus appearance on pseudocolor sheen that you get in young patients. Something a little bit abnormal in the center that you see more on OCT. What do you think this could be? Any thoughts?
مين
That's his
بيحب
other
يجاوب؟
OCT.
شو برأيكم عم يصير هون؟ Retinitis, Sarah said.
Excellent, very good. So
Excellent.
retinoschisis, and you think this is male, boy, classic sort of presentation in childhood usually. X-linked retinoschisis would be the #1 diagnosis. Obviously, I'll never make it so simple, but well done. That's right. So this was his working diagnosis, X-linked retinoschisis. His full field ERGs were normal, which is a bit unusual because normally you get an electronegative ERG or a reduced beta A ratio. Not impossible, but certainly it's unusual for X-linked retinoschisis. Then he still had the gene tested, RS1, and it was negative. Actually, it was discussed with me, this case, and we just found that CRB1 is a gene, we hadn't just found it, CRB1 is associated with a very severe early onset retinal dystrophy, but we found that certain changes in this gene could give you something that looks like X-linked retinoschisis or just macular atrophy. And so that's CRB1 that we were used to. Recessive disease gives you terrible retinal degeneration and often macular thickening. But my colleague Cameron Khan had found these patients who just had maculopathy, and all of them had this rare allele on one side, and the other allele could be this or something else. And you can see C.498 to 506 means that these bases between 498 to 506 were deleted. So how many is that? 498 to 506. How many is that? Who's good at maths? Including 498 and 506. What do you think? Anyone good at numbers? So people often say 8 because that actually,
Eight,
in
yeah.
fact, just
They fell for it. 8. 9. Somebody
good.
said 9.
And just while you're thinking, just give me 1 second to open the door. Sorry about that.
Sure.
That was your thinking time. Sorry about that. My son was at the door.
Done.
Yeah, 8
Yeah, no
8 is a
changes,
good
sir.
thought. Anyone said anything else? But it's got to include
9.
498 and
Somebody said 9.
506.
Ahmed said
Excellent.
it's 9.
Yeah. So think 498, 499, 500, 501, 502, 503, 504, 505, 506. That's 9. So 9 is a multiple of 3, and therefore it's in frame, and that's why it just takes out 3 amino acids 167 to 169. And that might be, remember I said in-frame deletions often aren't as bad as frame-shifting ones. That might be why these patients are milder, or it could be some other reason. So that was interesting. So I predicted that he could have CRB1, and one of the mutations would be this. And this is the email I got back from my colleague. I looked up the patient that we talked about yesterday, and you were, of course, completely right. I'll only show you the emails when I'm right? I'm not going to show you the ones where you were completely wrong. Anyway, it was CRB1, and one of them was that mutation. They were his 2 mutations, and one is the one that we predicted. So we're getting good at recognizing this now. If you see something that looks like X-linked retinoschisis, but they've got normal ERGs, or it's a female, right? They're not going to have that. Then always think of CRB1 maculopathy as a possibility. Final case. This was an 18-year-old male, poor night vision since a young age, subnormal vision in both eyes, a few other things in his history. This was his family tree. So that's him affected, and you can see there's a cousin and a great-grandfather affected. What do you think about this family tree? What do you think the inheritance might be?
فكروا شو بناء على هذا، بس عنده ابن عم وجد، أبو الجد منصاب. شو برأيكم نمط الوراثة؟ هل هي سائدة، متنحية، X-linked؟ Somebody said X-linked, somebody said recessive.
Yeah. So recessive well, is very unlikely, I think, because unless there was consanguinity or some, very narrow gene pool, because you could get a couple affected in a recessive, maybe like we call it pseudo dominance, but to have, it means that her sister, you know, partnered with someone completely unrelated to that person, but still he was carrying something very rare in that same thing, and then that happened up there as well. Unlikely. So I would say, yeah, an autosomal dominant with variable penetrance is possible. We could say that these people in between weren't affected, but those were. But then we also see it's only males, right? And they're only connected through females. So X-linked, this kind of screaming that this is probably X-linked. And again, this is why I always like to look at the family tree, because then you see who's a circle and who's a square. If he just tells you my cousin's affected, but that could be his dad's brother's son or his mum's brother's son or something like that, that would exclude X-linked. But here you can see mum's sister's son or mum's dad. That's very consistent with X-linked inheritance. So that's kind of top of our list. This was his fundus appearance. I'll go quickly. It looks a bit abnormal, but he's a high myope. So actually, all of these things are really just consistent with high myopia. He's got a bit of a dome shape in the left eye, thin choroid, but nothing in terms of degeneration. He was recruited to the 100,000 Genomes Project. Negative result. So, however, we had his ERGs from age 5, and these were skin ERGs and a bit noisy, but there were still some features that are very suggestive of something called incomplete CSNB. And that's what Tony Robson, that's a young Tony Robson there, who's currently our head of electrophysiology, had said even at that time, I think this could be incomplete CSNB, although, there are other causes as well. And when we look at what the causes of incomplete CSNB are, there's only one X-linked cause. That's this gene, CACNA1F, CACNA1F. And that tells us, they've missed the diagnosis somehow for whatever technical reasons, but we only need to really look at that one gene. And when we looked at that one gene, we found that he had a frame shifting variant there. That was the cause. And just for some technical reasons, they hadn't picked that up. But the phenotype and the X-linked inheritance was really specific for this gene. So again, same sort of messages. Now in many settings, we do all the genes. We still don't get the result, but the phenotype is still crucial in knowing where they interpret what they found or know where there was a missed variant. And a specific ERG findings in the context of an X-linked family history can really narrow the diagnosis. And that's that algorithm that I already showed you before. So in conclusion, sorry, I've run over quite a bit, but I find this very exciting and passionate about this topic. But the final slides is we're trying to establish a molecular diagnosis for many of our patients where we can, and I've given some of the reasons. We're getting more of a picture of the overall burden of disease attributable to each gene. We're finding that mutations in the same gene can give you different phenotypes. So I used to think genetics was clean, right? One gene, one phenotype, not messy like uveitis, don't know what's going on. But it's actually not one gene, one phenotype. Even sometimes one variant gives different phenotypes, and we're trying to understand why. Some are the target of novel therapies, and we're still discovering new genetic causes, new mechanisms, new associations. So things are still very fast moving, but frustratingly, the treatments, it's hard to develop treatments, but we're hoping that more will develop in the next few years. Thanks very much, and happy to take any more questions, and happy to get any emails as well.
Thank you so much, Omar. This was really good. Very, very interesting and very easy to understand. Excellent cases. Thank you so much. حدا عنده سؤال؟ حدا بيحب يسأل الدكتور عمر أي سؤال قبل ما نختم جلستنا؟ Any questions? How to get melanoma-associated retinopathy from CSNB? How to get? How to differentiate, I think.
Oh, how to differentiate. Yeah, good question. Yeah. So the ERGs are identical, because both give you on bipolar cell loss, but the history will be different. So someone with complete CSNB will have night blindness from childhood, and they're often a high myope. Someone with melanoma-associated retinopathy, either they've got a melanoma, but we have diagnosed it even before the melanoma was found in a patient or two. So sometimes you won't know about it, but they'll usually have recent onset symptoms of either night blindness or photopsia. But we have, sometimes those visual loss of unknown origin, and the ERGs pointed to melanoma-associated retinopathy, and then the patient had a PET scan, and the melanoma was found.
Thank you. There's another question that was asked before. Has CRISPR gene editing any role in the foreseen future?
Yeah, good question. Absolutely. So people are looking at that as another possibility of directing. It's still sort of gene directed, but it's directing and editing a particular gene. There's lots of research going on, and that might be especially for dominant disease, where when replacing the gene might not work, because in dominant disease you've already got a good copy of the gene. So it's that dominant allele that's doing something bad. How can you silence it? Maybe CRISPR would be a possible way of doing it. The concern at the moment is off-target effects. You do something and it starts doing something else to your other genes and causing other problems. But hopefully in the future, it's being investigated now. So I'd expect that to be something in the future as well.
Thank you so much. We don't have any more questions, but I think I would be really grateful if you can email us, the link or how to register with the meetings, the regular meetings you have. And I'm sure people will be interested to join that if it's once a week or once a month even, just to get more cases in. يعني بشجعكم إذا عندكم حالات من الأمراض اللي أنتم بتشوفوها بالعيادة تبعتوها للميتنج تاع مورفيلد. من كل أنحاء العالم الناس بتشارك فيها، فيعني رح نطلب من الدكتور عمر إنه يشاركنا اللينك ونبعث لكم إياه إن شاء الله بالمبادرة. If you share it with us, we'll send it to the wider group, and hopefully they can.
Yeah, absolutely. Actually, there's no link to be on the list. Just email me, and then I email my colleague Hagar. She's an excellent retinal specialist who works with me. She manages the mailing list, and then we send out the link every Monday to the list. Right. So just send me an email, say I'd like to be added. If you don't hear from me, send me another email, because that's quite often, unfortunately. And then we'll add you to the list, and then you're welcome to join in. It's on the Zoom, 5:30 p.m. UK time to 7 p.m. And then the other thing is, if anyone wants to visit Moorfields sometime, do feel free, and you could, maybe see our inherited retinal disease clinics if you're interested in the future. Do get in touch. But yeah, we'd love to have you join our online case discussion.
معناتها بنشارك الإيميل. We will share your email with the wider group if that's okay. So you'll be bombarded with emails now.
No worries.
Well, at the end, again, thank you so much. It was really a pleasure having you. So good to hear from you and learn from you. I learned a lot, certainly. And hopefully, inshallah, we'll see you again soon. Thank you, everyone.
Great. Thank you very much.
شكرا لكم. شكرا للحضور جميعا، وإن شاء الله نلقاكم على خير. السلام عليكم.